Good afternoon and welcome to NOCC's Ask the Expert series. I'm Alana Feuchter, Senior Manager for National Programs. Today we are delighted to discuss genetics with Shelly Cummings, Director of Oncology Medical Affairs with Myriad. This week, the final week of Ovarian Cancer Awareness Month and the one leading into October's Breast Cancer Awareness is known as HBOC Week for hereditary breast and ovarian cancer. It is our hope that after this session, survivors will understand how genetic testing can impact treatment. And for family members, it will clarify who might be at risk for a mutation and what they can do to possibly prevent a cancer diagnosis. We encourage you to use the chat box below to send your questions. We will leave time at the end, but keep in mind that we are encouraging only general questions that will pertain to the larger group. We encourage you to speak with your own oncologist for individual questions. Now, I'd like to turn this over to Shelly.
Welcome, and I'm honored to have an opportunity to speak with you today. And as Alana shared, I am the Director of Oncology Medical Affairs at Myriad Genetics. For background a little bit, I'm a certified genetic counselor. I've been in the field of genetics for over 25 years, both in academic and in industry. I was a genetic counselor at the University of Chicago for 13 years, and I've been with Myriad since 2008. So I have seen the world change dramatically, maybe not as dramatically as the last 6 months. The world has changed, but significantly in the field of genetics over that time span. So we're going to spend a little bit of time this afternoon discussing a few topics. I'm going to give a little primer on Genetics 101 so that we all understand what we're speaking about when we talk about genetics and genetic testing, specifically in terms of ovarian cancer. Alana is graciously going to share her personal story with us. And then we have a call to action at the end of this that I think that you will all recognize is extremely important. So that is going to be our agenda for the next few months or few minutes, excuse me. And as Alana said, she will be taking your questions throughout, and then we will have time at the end for some question and answers. So I wanted to start off by just laying the groundwork about who we are and where we come from. And if I can take you back to maybe your 7th or 8th grade biology class, every cell in our body, or the majority of every cell, you might have learned, contains what's called the nucleus of the cell. And that's like the brain of the cell. It's telling that cell how to act and what to do. And within the nucleus of the cell is our basic genetic material, our chromosomes. You get half from mom and half from dad. And what makes up the chromosomes are our genes. And the genes are our DNA. Right here, you can see this twisted spiral helical, kind of think of it as a spiral staircase. And what makes up the genes are known as chemical bases, and they're abbreviated in a G, a T, and a C. And it's really this very specific pairing of these letters that make up our genetic alphabet. And that genetic alphabet is put in a very specific order to produce a protein. And that protein serves a very specific function in the body. And when there is a change or variation, or you might hear the term mutation or alteration in the gene or this genetic makeup, then sometimes not enough protein is produced or no protein is produced. And when that happens, then that cell doesn't work properly, and that's when problems can occur in the body. So that is really the basic fundamentals of genetics. As our DNA's goal is to produce a protein, and if that protein isn't produced in a sufficient manner, then problems could occur in the body. When we sit down with individuals, with your doctor or with a genetic counselor, one of the very first things they do is ask you specific questions about your family history. And the reason why they take so much time asking you questions about your family history is they're trying to categorize if what you have in your family fits into certain buckets that we have traditionally thought of. One is sporadic cancers, and that's where the majority of cancer cases are lumped into. Sporadic cancers are cancers that occur usually at an older age. You don't see a pattern of cancers coming down through the generations, and you don't see a lot of those cancers in the family. In the middle risk category is called familial cancers. You might see a few more cancers in that family that has that familial risk, but you don't see a pattern coming down the generations. And you don't have as many as what you would see in sporadic cancer families. And then the highest risk group that we think of are those that have a hereditary cancer or an inherited predisposition. And you can see in this cartoon, they make up a smaller percentage of the population. Another way to think of this is the pie graph that we have here on the right. About 65% of cancers in the population are sporadic. About 15 to 25% are categorized as familial, and about 5 to 10% can be hereditary. And what I'm talking about here is of all cancers. We're just lumping them in all together. There are some subtle nuances when you dig into different types of cancers, let's say breast cancer or ovarian cancer. And we'll talk more about ovarian cancer in a moment. Now, to take a quick step back, I wanted to share with you exactly our thought process in the differences between the development of sporadic cancer and hereditary cancer, or the inherited forms of cancer. I mentioned that your chromosomes come in pairs, as so does your genes. So this little cartoon is representing your chromosome. This is in no way what chromosomes really look like, but bear with me here. So we can pretend like one comes from mom and one comes from dad. And over time, when we're thinking about sporadic cancers, a gene in this chromosome somehow becomes damaged. And this can happen because somebody is exposed to something. They might have lifestyle factors that influence their risks, such as smoking or having a poor diet. But something happens and that gene is damaged. But they don't develop cancer because they have their partner gene over here that is still working and protecting them from getting from that cell becoming damaged. But over time, it's possible that in that same cell, the partner gene becomes damaged. And so the two genes that were normally working here are now damaged or mutated or altered in a way that the normal function of those genes is not taking place. And so when those brakes are off, so to speak, then that cell just goes into overgrowth and a tumor develops. And that's the basic definition of cancer, is the overgrowth of cells. We have genes in our body that control this overgrowth of cells, but when those brakes are damaged, that's when a tumor can develop. And this develops in a single cell. This is not the type of cancer right now that we're talking about that is inherited. So this is the vast majority of those diagnosed are sporadic. And you can see this is what we call the two-hit hypothesis, where it takes one hit here and a second hit here before the cancer can occur. Now, when we think about this in the hereditary cancer families, an individual that has an inherited type of cancer is born with that first hit or that first altered gene. But they typically don't get cancer as a child at a young age because they still have that protected other gene that is working in its proper fashion. However, that second step happens and that other gene gets damaged. But because they were born with this first altered gene, it's a shorter time period to get to this second hit. And that's why individuals that have inherited types of cancers tend to get them at a younger age than what you would expect for that type of cancer. So it is still possible for individuals to have sporadic cancer at a young age. And I use testicular cancer as an example. Testicular cancer typically occurs in males in their 20s and 30s, which is very young, but that's the average age for when testicular cancer tends to occur. But prostate cancer doesn't tend to occur in the 20s and 30s. Its average age is much later. And for whatever reason, certain types of cancers tend to occur at later ages, whereas the inherited forms tend to occur at younger ages because they're one step further along that process. I want to spend just a little bit of time defining the difference between somatic and germline mutations. And I'm going to keep those titles up there, but I'm going to use the term tumor testing and blood or saliva testing, or really when I think of germline testing, it's looking for changes that are inherited that you can pass down to the next generation. So many times people don't understand the terms somatic and germline, but I'm trying to differentiate that when somebody talks about somatic, they're talking really about something that is just occurring in the tumor. So all of cancers have their own type of genetic makeup in that tumor. It's something happened that caused that tumor to go haywire and to get overgrown. So something in that genetics of the cancer, not necessarily the genetics of the entire individual. The genetics of the entire individual is when we think of something that's inherited. So I'm spending a lot of time differentiating those two because there tends to be a lot of confusion around it. So every cancer, as this diagram on the is demonstrating, has many somatic changes, many different types of changes that occur, which is what caused it to go on to become a cancer, that overgrowth of cells. And a somatic mutation is a change in the gene that arose in the tumor and is confined to the tumor. That's very important to remember. And that's where most cancers are sporadic. It's really just happens by chance. Whereas the germline are those inherited types of cancers where somebody is born with an alteration. They have a change in the gene that increases the risk for cancer. And that's the inherited forms. And that's around the 5 to 10% that I mentioned earlier. I mentioned that your physician or genetic counselor will take time to assess your family history, which is key to all of this, understanding and identifying who is at risk for an inherited type of cancer. And the reason why we do that is because we want to understand who is at risk and who might carry an altered gene. And in this cartoon, you can see that the father, with his 2 chromosomes below, is indicated as having a mutation or an alteration in one of his genes. And because he has this alteration, there's a 50-50 chance of which of his chromosomes he will pass down to the next generation. And same with the mother, 50-50. It's like flipping a quarter and getting heads or tails. On average, if you did it 100 times, you'd come pretty close to 50-50. And when we know what we know about inherited types of cancers, they are passed down either from the father or the mother. And this is really critical to remember because many times, particularly when we're talking about breast and ovarian cancer, families think that they can only get it from their mother. And that's absolutely not correct. These genes are on chromosomes that have nothing to do with the X chromosome or the Y chromosome. So this father has a 50-50 chance of passing this down to this at-risk child. The mom would pass this, oops, sorry about that. The mom would pass this chromosome down, and you can just see, follow it down and see. And these two kids would be the ones that are at risk because the mutation lies here. That's how this inherited forms of cancer are inherited both to sons and to daughters. Now, specifically, want to talk a little bit about genes that we know are related to an increased risk for ovarian cancer. So, as Ilana mentioned in the beginning, this is the week for focusing on HBOC syndrome. And we know that 1 in 7 ovarian cancers is caused by mutations in the BRCA1 and 2 genes. And these are the two most well-known genes associated with breast and ovarian cancer. And they've been the most well-studied. And over time, as we've looked at multiple different types of families, we have seen that about 24% of ovarian cancers may be due to an inherited susceptibility, which is higher than the percentage of many other types of cancers. And so that's why it's very important to identify those that are at increased risk so they can be screened and followed appropriately. But in addition to the HBOC syndrome, we know that there's a colon cancer syndrome it's the most common form of inherited colon cancer, is known as Lynch syndrome after Henry Lynch. And it's caused by mutations in any of these 5 genes listed here. The risk for ovarian cancer and Lynch syndrome is about 12%. And I'm going to show you a bar graph in a few moments so you can get a full appreciation for the level of ovarian cancer risk in some of these genes. So number 1 and 2 are the syndromes that are most commonly associated with ovarian cancer. But as more testing is being done beyond looking at those 2 syndromes using multi-gene panel tests, where multiple genes are on a single test and you can look at lots of genes at the same time, a lot quicker, a lot cheaper than it ever used to be. We're discovering more about genes that we thought we knew about that are associated with ovarian cancer in ways that we didn't recognize previously. So this is a list of some of those genes here. And what I've done is I've put these in a bit of a graphical format so you can see that while BRCA1 and 2 is still responsible for primarily the ovarian cancer, there's still quite a few other genes that I've listed here. And what this is showing you is the ovarian cancer risk if somebody has a BRCA1 or 2 mutation. It could be as high as 63%. So all of these numbers here is, you could put up to, the word up to in front of them, just so that you can get an appreciation of that. So you can see that there are quite a few that have an increased risk. The general population risk is about 0.7 to 1.2, depending on what you're looking at. But you can see all of these are much greater risk than that. And then there's a link right here. As we learn more information, these figures are updated regularly in terms of when papers come out and we have updated information. Now, this slide really depresses me. So I'm sharing this because genetic testing has been recommended for all patients that have epithelial serous ovarian cancer, peritoneal cancer, and fallopian tube cancer since 2008. And roughly about 27% of all patients with ovarian cancer are receiving testing, genetic testing, to learn their risk. And it was actually Dr. Thomas Herzog that presented this data at an SGO meeting in 2015. And honestly, these numbers have not gone up since then. if you look at this map of the United States, you can see that we are way far from getting 100% of patients tested. The best state is Rhode Island, little Rhode Island over here, with 44.4% of ovarian cancer patients being tested. You can look for your state on here and see what's happening, and try to have some grassroots efforts to make these numbers go up, because this is really abysmal. And the reason why this is becoming increasingly important is because now we have FDA approved treatments. And some of these treatments are based on knowing if somebody has a germline BRCA1 or 2 mutation. And so it's not just to know the genetics and to know the risk for family members, which is extremely important, but it's also to understand what are your treatment options, which have never been available before. So to feed off of that, why is testing important? Why should individuals and their families want to consider genetic testing? Well, it can help identify the cause of your cancer. It can give you an answer to what might be occurring in your family or in you if you don't even have a family history, because we know that you might not have a family history but have an altered gene. As I mentioned, it can help identify treatment options, including some of these newer approved FDA targeted therapies. This is really the critical aspect of precision medicine. It can also open up the doors for different clinical trials. And also, it can help inform family members who could be at risk, who might not recognize that they are at risk, and they might make different decisions if they knew that they had this elevated risk. If you know what your risk is, then you know that you can have different options to manage that risk. Family members can craft out a plan with their healthcare provider. They can have different types of conversations that they might never have had if they didn't know that there was a genetic relationship to the ovarian cancer in the family. And it's important to have these conversations. A lot of questions have come up in the past when I've given this talk about, I've talked to my doctor, but they were afraid that I would get something called a variant of uncertain significance, or a finding in these genes that we just can't determine what it means. It's not an unrealistic statement, because it does happen. We can find variants of uncertain significance. The important thing is to use a lab that is constantly in real time evaluating those variants of uncertain significance. And what that means is they have invested in their variant reclassification process. They are constantly developing new techniques, and they're improving the science of that variant classification. So at Myriad, we have our variant classification program is called MyVision. And we have been doing variant classification since the very beginning of genetic testing in 1996. And when a variant is reclassified, we send an amended report to the ordering physician, regardless of how long ago it was. And I, for example, attended ASCO 2 years ago, because this past year was virtual. And I had a nurse come up to me after I was giving a presentation, and she thanked me for working at Myriad because her family was just given an amended report from the initial testing that was done 12 years earlier. And so now she had a definitive answer to that VUS. And recently we partnered with UT Southwestern to look at some of our data. And we looked at data from 2006 to 2016. And we had classified over 2,800 independent variants, which provided clarity to 52,000 patients. And we have multiple studies actually that have shown that other labs that have a variant classification process or don't, but issue a VUS, we are able to give results to over 42% of those BRCA VUS classifications. So it's a critical component of what we do every single day. And we call this our lifetime commitment classification because we think it's important to give a definitive result to patients. And now I am going to pass it to Alana, who is going to share her story with us.
Thank you. So I'm going to share where it all started for me. My mom was diagnosed with cancer of unknown primary in 2012. And when you have a cancer of unknown primary, it means that they don't know where the cancer came from. And in order to treat it, it's pretty difficult if you don't know the origin. So among the tests that my mother received was genetic testing. I went with her to the genetic counselor, and knew that, of course, my risk was 50%, as we have just discussed. And when it came back that she did carry a BRCA1 mutation, I got tested myself. I also learned through my experience with genetic counseling that the best way to reduce my risk of ovarian cancer was to do a preventative oophorectomy, which is a removal of the ovaries and the fallopian tubes. So I went ahead and I scheduled one with a gynecologic oncologist, which is, the expert in the field. We did pre-tests ahead of time, which included my CA-125, 17 at the time, and a vaginal ultrasound, which showed nothing. So I scheduled my surgery, and it wasn't until I woke from surgery that I learned that I had stage 2 ovarian cancer. So, as it says on here, my mother likes to say that she gave me life twice, because if she had not known her own genetic risk, I never would have gone to get tested, and I would have obviously probably been diagnosed at a much later stage. So I think it's just a personal experience, but I like to share that it is important for you to know your family history. I have daughters of my own who have not yet been tested. I see there's some questions about that we'll get to eventually, about when children should be tested. But I do know that this is in my future for them, and they know that it's in their future as well. So I think hopefully that gives you just a little taste of why genetics is important.
That's great. Thanks for sharing that, Alana. I would agree. Your mom gave you life twice. That's a very powerful statement. So now we have our call to action. And because treatment guidelines for ovarian cancer state all patients and families should have germline testing, the call to action is to talk to your doctor. Talk to your doctor about the options for you to learn your risk. Guidelines have been available since 2008, and we have less than 70% of patients who are not receiving, genetic testing. And there are multiple ways to have genetic testing done. And there's a link here to learn about a 100% testing option that you can do in the comfort of your home. We've partnered with Genome Medical that has genetic counselors who can speak to you and talk to you pre-test, post-test, get you your results. And it's a very convenient way to do it. You can also partner with your doctor who might have access to genetic counselors, or you can look on the National Society of Genetic Counselors website, nsgc.org, for a list of genetic counselors as well. Now we're going to open up to question and answers.
Okay. We can take the slide down if you'd like. So we do have a number of questions, and I will just start with the first one that we received, which was, can environmentally damaged genes be replaced with healthy genes by the body over time, or does that damaged gene always stay in your body?
That's a loaded question at multiple levels. So it sounds like this person is asking, can we do gene editing to a certain extent by taking out that altered gene that might have been the environment.
Mhm.
You know, we know of risk factors for cancer. And I mentioned the smoking and I mentioned the poor diet, but you can have people like Winston Churchill, who had the worst diet, who smoked his entire life and did not die of cancer at all. And then you can have a professional athlete who has the best diet, the best lifestyle, healthy, who gets cancer at a very young age for unknown reasons. So it's very difficult to pinpoint the environment to the cause. We just know that people that have a certain collection of risk factors have a higher probability than others. So we can't say that this environmental risk factor mutated this gene to be able to say that we've altered it enough to cause it. We can't go in and do gene editing. We're having trouble with doing gene editing in some of the little bit more straightforward genetic syndromes, and cancer is not straightforward. So the answer is no to your question. It's a very well thought out question, but it's we're not there yet.
I just want to piggyback off of what you said, and this is not necessarily environment. This is obviously based on the genetic mutation. But you were talking about how different people can be eating different foods or exercising, and that was one of my questions because my mother and I have the same. We have the same mutation. We have the same BRCA1 mutation, and yet she did not get ovarian cancer until she was in her late 60s, and I was in my mid 40s. And I always wondered why that would be because I was the one who ate healthy and I exercised, and she didn't. So from that standpoint, it doesn't make any sense. But
Right.
but obviously, there was some other unknown reason for it.
Yeah, you were around in a more developed time of the world where, more plastics, more processed food. Not that you ate any of those things. I'm just tossing out things that could have been, but there's a lot of variables between the generations of what people are exposed to. Yeah, so it's there isn't anything we can put our finger on except for a handful of things, even when you know that there's a mutation in the family.
Right. Another question was, at what age do you recommend my daughters receive genetic testing? I received surgical treatment this summer, uterus and tubes removed, but left ovaries. So I'm guessing that was somebody who had the gene and was doing preventative surgery.
Okay.
It sounds like to me, and they want to know when their children should be tested.
They did preventative surgery but kept their ovaries in.
Well, because that's the recommendation right now. If you're under a certain
Young.
age, you
Yeah.
keep your ovaries, and then when you reach a certain age, to take the ovaries out because they do think it starts in the tubes.
Yeah. Right. So the guidelines say age 18. And I think that's an arbitrary age because you're an adult and you can make your decisions. That's when they have a conversation about genetic testing. Okay, not when they have surgeries. Um, the really the discussion should begin when individuals are concerned about their risk. I saw patients we had discussions with 17-year-old daughters because they knew what was happening in the family and the family wanted them to be involved in the conversation. But the guidelines will have screening or talk about it at age 25 to have the more thought out conversations. Typically, you don't see ovarian cancer and breast cancer at those young ages. You see those cancers occur later. But then the guidelines will also say to begin screening 5 to 10 years younger than the earliest case in the family. So we're not going to screen a 15-year-old, if somebody, had it at 20 or 25. So it's a balance between what is happening in the family and the maturity of the daughter or the son that you want to have the conversation with. And there are guidelines that can navigate through that. And that's honestly where a genetic counselor will come in handy to help give you the right wording and the phrase. But kids know what is happening, even if you don't say it. And so having that honest conversation is the best way to open the door so they feel comfortable to have the conversation, even if they don't want to have testing. they feel comfortable coming to you with questions.
Excellent. The next question is, if my test was negative, do I need to worry? And I'm guessing that means for future generations
Sure.
or family members.
Okay. We'll cover it all. It depends what test you had. I don't think you need to worry. I'm guessing that you had probably a good high quality test, but as I mentioned, there have been advances in the testing that's been available. Initially, people were only tested for BRCA1 and 2 because that's all that was available in terms of testing at the time. And unless you had a colon cancer syndrome, you might have been tested for the Lynch syndrome genes. But now with these multi-gene panels, and even, let me take a step back, even BRCA1 and 2, some subtle changes happened to the testing there where they went back and we knew that some large rearrangements should be evaluated. So it depends when your initial testing was done. It depends what type of test you had. If you had a large multi-gene panel test, 35 genes, then or larger, the majority of the genes on that test are going to cover that list of ovarian cancer genes that I showed. So it's hard to definitively answer your question because it depends what test you had, when you had it, and what genes were included in the test.
Okay, this kind of ties in nicely. This question is, I had stage 3 ovarian cancer in 2019 and survived it. Congratulations.
Mhm.
Do I need to get tested now?
Stage 3 ovarian in 2019, and
Mhm.
you've never been tested.
This is all I see.
Yes,
in here.
right.
Yeah.
Yeah, you answer it. So yes, I mean, it's reasonable to consider and have the conversation with a professional because um, if you have at-risk relatives, and knowing if you're interested in knowing the relationship with your ovarian cancer and potentially a genetic susceptibility, then genetic testing is the way to determine that, even if you had it, 17 years ago.
Another question is, for those with a higher family history of breast and ovarian cancer, but who do not have a genetic mutation, what should be the screening protocols?
Hmm.
Is that a question for you or for the physician?
It's a little bit for the physician. The screening would depend on the individual that's in front of me at the moment. So I would consider their age. I would consider how close they are to those have had breast and ovarian cancer. If it's a third cousin, fourth cousin, I'm less worried than if it's a sister or a brother. It also would depend on, again, what test was done to know if all the genes were included and who was tested in the family for that, let's say, multi-gene panel. There might be another person that might need testing to definitively know. So back to that diagram we showed where it's 50-50. If you test somebody and they don't have the mutation, but you think there's a mutation in the family, you just know their genetic information. You'd need to test the other individuals in the family to know if they inherited the mutation. So it could be possible in this scenario that you just gave me, this person is negative, but there could be something present in the family, if you're following me.
That makes sense. Yes. My mom and sister are BRCA2 positive, but I am negative. Do my sons need genetic testing?
If you are negative for the same mutation in the family and there's nothing coming down on your husband's side of the family, I'm assuming this is a female asking this question, because again, it can be inherit for your sons, it can be inherited from the father's side as well as the mother's. Then the likelihood that your sons would inherit it would be only coming from the father's side of the family. And if there's nothing there, then the likelihood is very low. I bring that up because in Eastern European Jewish families, there's a higher probability for having changes in BRCA1 and 2. It's 1 in 40 for having a susceptibility just based on ancestry. So in families that come from that ancestral group, there's a higher chance of having these alterations in the genes.
Okay. Another question is about insurance. And does insurance cover the cost of genetic testing?
Insurance companies do. Initially, when testing was available, they did not. But most insurance companies have some kind of criteria for establishing if you are appropriate individual, and they typically follow NCCN guidelines, which is that guideline that I mentioned ovarian cancer has been in since 2008. And professional societies and other guidelines have it as well. Now, there could be some insurance companies that have a carve out or are a smaller insurance company, but the vast majority now cover it.
Okay, I know we have another question coming.
And let me add on to that one for a moment. In situations where insurance companies don't cover it, there are financial assistance programs at Myriad that can help with that to make that comfortable for patients.
Okay. I think this is our last question, but I do encourage other people to ask them before we wrap it up. What is Myriad doing to help physicians understand which Myriad product to use to ensure their patients receive the full complement of testing?
Okay. Myriad has spent an inordinate amount of time and effort trying to educate multiple provider types. So, general practitioners, which is frequently how women get their care initially, they go to their OBGYN or their GP, medical oncologist, gyne oncologist. We have field-based medical personnel, predominantly are genetic counselors or advanced practice nurses who've spent years in oncology, working with providers and educating them on the nuances of genetics, as well as the different products that Myriad has and how it can impact their patients, and which to use when, because if a patient's family has already had genetic testing, we're not going to have them get genetic testing again until we can figure out that it's an appropriate thing for the individual in front of us. So long answer is we are constantly trying to educate providers. We want to increase that 27% of ovarian cancer patients much closer to 100%. And the only way to do that is by educating at all levels: patients, nurses, genetic counselors, and all doctor types.
Okay, we have just a couple more that have come in. I hope that's okay.
Sure.
Joan is asking, my mom died of ovarian cancer 20 years ago, and she had her own genetic testing done 15 years ago, which did not show anything. She's wondering if she should be retested.
Yeah, so 15 years ago, the only game in town was Myriad, and we were only testing for BRCA1 and 2 15 years ago. So it would be worth having a conversation with her physician to understand what testing was done. If 15 years ago, it might not have included large rearrangement testing in BRCA1 and 2. So that's the first thing. And it certainly didn't include the other handful of genes that I mentioned earlier. So it is possible.
Okay. Some of these are somewhat repetitive. How frequently should you do genetic testing? And you just answered that.
Yeah, your genes are your genes. They shouldn't change over time. The question is the test that was done. That's what's changed.
Okay, I think this is kind of tying back again to the difference between genetic and somatic tumors. I have a friend who has ovarian cancer and tested negative for BRCA1 and 2 mutations, but was told she could have a tumor that would test positive for a BRCA mutation. So does that mean that a negative test for genetic mutation does not mean you will never get a genetic cancer? I think maybe what they're asking, maybe because your genes are your genes, as you just said. So to answer that, of course, your genes are not going to change. But yes, your tumor could have carry the BRCA mutation in it.
Yes. Yeah, there are a lot of there's a lot more somatic testing being done than ever before, because doctors are ordering these large somatic panels because it can give them information on different treatment types. And so in the somatic testing world, they're discovering mutations that sometimes overlap in the inherited world. And that's when it's very important that somebody is involved to have a discussion to bridge that gap between, we found this in somatic, in the tumor, does it mean something in an inherited fashion? And it's not always one-to-one. If it's found in the tumor, you need genetic testing in the blood or saliva to determine if it's truly inherited. I think that might have been a way to answer that question.
Yes, I think that was a great answer.
Okay.
Well, I see that we are out of time and also out of questions. So I want to thank you one more time for sharing your expertise. I think this was a lot of information, but obviously a lot of great information that was shared. This video will be on our website, on our Facebook page, and it will also be on our YouTube page. So if you think you forgot something and you want to go back and rewatch it, it will be available there. We do want to encourage people that there is a quiz on our website that you can take that helps identify whether or not you should be getting genetic testing. And I think that's it. Am I forgetting anything, Shelly?
I don't
You
think
want
so.
to say in closing?
No,
Okay.
thank you. Thank you for having me. I enjoyed answering all of your questions.
Excellent. Well, thank you, and have a great day.